Hello and welcome to Everyday Medicine. I'm Dr. Luke and I'd like to thank you for joining me on this podcast series where we share conversations with colleagues exploring their special interests in medicine and bringing insights, ideas and advice which I hope will be applicable for our medical practices. In this episode, we talk with an expert on oral medicine. But before doing so, for Australian audiences, listening does give you eligibility for your CPD, so log in and add this as an activity. You may also consider journaling, reflection, and adding to the review and performance section in your CPD. Well, good oral health is fundamental to overall health and well-being, and a person's quality of life is compromised without it. And by oral health, we're referring to the condition of a person's teeth and gums, as well as the health of the muscles and bones in the mouth. And tooth decay, gum disease, and tooth loss affect many Australian children and adults and contribute 4.5% of all the burden that non-fatal diseases places on the community. Now, most oral health conditions are largely preventable, and it is estimated by the World Health Organization that oral diseases affect close to 3.5 billion people worldwide, with 3 out of 4 people affected living in middle-income countries. Maybe their exposure to sugar is a factor here. Well, many factors do contribute to poor oral health, including consumption of sugar, tobacco and alcohol, as well as a lack of good oral hygiene and regular dental checkups. Additionally, a lack of fluoridation in some water supplies and lack of access and availability to dental care impact adversely. There are also recognised links between poor oral health and chronic diseases, including cardiovascular disease, cerebrovascular disease, diabetes, oral cancers, pulmonary conditions, and adverse pregnancy outcomes. Socially disadvantaged and indigenous Australians are more likely than others to experience untreated dental and oral disease, which negatively impacts on their health outcomes. Well, this important subject is certainly worthy of further discussion, and it was a pleasure to meet Dr. Asef Anwar, a registered dental surgeon with a passion for oral medicine. He's a graduate of the University of Sydney Dental School and has degrees as a Bachelor of Medical Science, as well as being a Doctor of Dental Medicine. He's worked across private practices in both New South Wales and Victoria and has a special interest in complex full mouth rehabilitation, dental implants, oral surgery and cosmetic dentistry. He's committed to continuing education and research and is extending his knowledge and studies as the Oral Medicine Registrar at University of Melbourne. So it was a real pleasure to conduct a conversation with him on the subject of oral medicine, exploring its interface with the practice of general medicine. And I was curious to learn more about the relationship between oral, mucosal and dermatological conditions, oral manifestations of systemic conditions, orofacial pain management and oral cancers. Another area of interest I was keen to explore related to the treatment of obstructive sleep apnea with mandibular advancement and dental splints, as well as broaching the subject of dental implants. Now, with these points in mind, please welcome Dr. Asef Anwar to the podcast. Dr. Asef Anwar, welcome to Everyday Medicine. Thank you for joining me. Asef, great privilege to have you here, expert in oral medicine. I want to talk with you about your journey and about oral medicine and what we can learn from you as doctors in primary care. So thank you very much. Tell us about your journey, Asef.
No, thank you, Luke. Thanks for having me. So oral medicine is a specialty branch of dentistry, and essentially the best way to describe it is it lays at the interface between medicine and dentistry. So any sort of conditions, any pathology, diseases of the oral and maxillofacial region, that is, I guess, an oral medicine specialist practice. So my journey started, I did my undergraduate degree at the University of Sydney, which was a 3-year bachelor's degree. I went on to complete a Doctor of Dental Medicine, which is another graduate 4-year dental degree. After having worked in numerous clinics across regional New South Wales, regional Victoria, and actually Melbourne rather, I embarked and was very fortunate enough to get into the specialty training program through the University of Melbourne, which is another 3 years full time, and it's never ending, I guess. So yeah, it's been quite interesting, and definitely I think this is a specialty that's up and coming and really making its mark, at least in the dental world, and also with a lot of our medical colleagues as well.
As if you're very well trained, and you have to be very dedicated to enter this kind of training that you're doing in oral medicine. How many trainees are being accepted say Australia-wide for this? It's
Yeah.
what's the number that we're seeing?
So Australia-wide, there's 4 universities or 4 states that offer the such training program for the oral medicine. Typically, it's 1 to 2 per state per year. My cohort or my intake was just myself, but the following year was 2 people that got into the program as well. But typically Australia-wide, I'd say there's about 7 to 8. That's probably somewhat, the average number per year.
It's a small, so it's super specialised, and we're lucky to have people that are training like you are and are dedicated enough to enter this field. Just tell us a little bit about that interface between what you're doing, oral medicine, medicine in primary practice, and I'm wondering as well if there's a little overlap with ENT. Whether there's a bit of competition between ENT and what you're doing. Can you just explain that and take us through that? Like, how would we understand about referring to you rather than, say, someone who is an ear, nose and throat surgeon?
Yeah, absolutely. So definitely, I mean, the main thing that I probably use to describe, what an oral medicine specialist does and how I explain it to my patients, the ones that are referred to me and are somewhat new, I guess, to this sphere, I explain it to them that, this is anything in the mouth, anything within the maxillofacial region that's typically non-surgical or non-interventional in that manner is something that we specialize in. So a lot of diagnostic, a lot of I guess investigations, these types of procedures or treatments rather, and then obviously depending on what the diagnosis is and what is the required intervention, that's when we work within a team to appropriate the correct treatment. ENT, obviously being a surgical specialty, there's a lot of overlap. So we probably see a lot of early, oral squamous cell carcinoma patients that have ulcers or have any sort of lesions that present to us. And I guess once we confirm the diagnosis, then it does go through the, multidisciplinary approach to a patient's treatment and journey. But I think a lot of it, rather than ENT, I'd probably say with maxillofacial surgery and maxillofacial pathologists in that regard. So we do have a lot of overlap, and we do have a lot of combined clinics that we run, and that, I guess that is it's a bit of a territorial kind of, how do I explain it? Territorial, not fight as such, but an overlap between a few specialties in the head and neck region.
Yes. Well, I'm guessing too that dentists might be more inclined to think, oh, we'll send to an oral medicine trainee who's been a dentist, whereas perhaps in primary care we might be, up to this point, perhaps being ignorant of your training and your specialty and your interests. We might have been more inclined to refer off, as you say, to a facial maxillary surgeon or an ENT. But it's nice to know you're there. And I'm just thinking about the sorts of conditions that you might be seeing. Can you just take us through the sorts of things that you are seeing and treating and managing?
Yeah, sure. So a lot of it does present with dermatological or mucosal lesions and conditions in the mouth. So any sort of autoimmune, immune-mediated lesions, so such as oral lichen planus, mucous membrane pemphigoid, pemphigus vulgaris, any sort of infections, any sort of ulcers, lumps, bumps, anything that's in the mouth and face that's not of normal appearance and bit of a sinister kind of onset. These are the things that we typically get referrals from. There's a lot of oral facial pain that we also manage as well. So there's a condition called temporomandibular disorder, which is very, very much prevalent, and especially more so, I notice it, at least personally, after COVID. I find that a lot of younger patients are coming in, jaw pain, earaches, these types of things. So that's something that's probably we see routinely and daily. We also see a lot of patients that present with, sort of oral dysesthesia or changes in the taste and smell, etc. So these are the things that commonly refer to the department. But then on top of that, any sort of, I guess, dental intervention that's needed for medically complex patients with previous head and neck radiotherapy or cancer, etc., that also have the, mucositis or for example, graft versus host disease in the mouth, etc. So those are typically some of some of the conditions that we manage.
Yeah, the more specialty sort of dental work
Correct.
comes your way, those complex patients that have got multidisciplinary.
Yeah, we say yeah, dental work, but I guess it's never teeth that we treat anymore.
Right. Yes. Yes.
It's the mouth rather.
You're out
So
of teeth.
yeah, it's been a while since I've been able to, do some, I guess, dental intervention. But yeah,
What about your dad? I bet you he asks you to
yeah,
help him from time to
he does. He does. So general practitioners, and
Yes.
this is a fun point, or funny point rather.
Yes. Yes.
So I think GPs, they get a lot of, I guess, being a primary care physician, they see a lot of patients that present to them with any sort of changes or concerns with the mouth and face, and so they really they're not one to necessarily diagnose straight away. They do have more of a kind of a generalized approach, I guess, to that. And in that case, when I chat to my father, we definitely have a few conversations where I really query or question whether it's a infection, whether it's something else. So yeah.
It's interesting. Yeah. It's nice to have a little family feud on a technical or a sort of intellectual level. Tell us about some red flags. Like if we're looking in the mouth in primary care and we see certain pathologies, what are the sort of things that are red flags for us? How can we sort of like perhaps be a bit more certain that it's not an infection and something we should just monitor for a few weeks, or something we should perhaps be thinking about referring a little bit faster to you? What are the sort of things we should be really looking for?
Yeah, absolutely. And this is a very common question that's probably asked of an oral medicine specialist when we do speak to other colleagues. And I mean, the biggest thing is the mouth is, it's made up of a few different structures. There's muscles, there's mucosa, there's, nerves, blood vessels, etc. within the oral cavity rather. So when you look in the mouth, the basic way to explain it is the mouth has pink soft tissues all around. So anything that's, I guess, varying or deterring or differing from that. So things such as like anything that's red, that's white, that's a new lump or bump in the mouth. These are all initial, somewhat to an extent, a red flag that does warrant some sort of investigation to confirm what it is. On top of that, if there's any sort of non-healing or persistent ulcers in the mouth, or there's something that's really, it looks quite sinister. So it's mixed, it's non-homogeneous, it's red, white, a rough surface, these types of lesions presenting, these are things that absolutely should be investigated and should be managed. We see a lot of immunobolus patients as well. So as I mentioned, patients with pemphigoid or pemphigus. These are obviously they could be quite debilitating for the patient. They can't eat, they can't drink, they can't talk properly.
Yes.
So I guess anything that's somewhat abnormal in appearance. So anything that's not pink in a very simplistic description.
There's a red flag there. Some of the things that we see occasionally during my endoscopy practice are, whitish plaques on the mucosa, and I'm thinking, oh, yeah, this is leukoplakia. Do you have a little heuristic, a rule of thumb that we should follow when we see someone who has leukoplakia? Sometimes those patients may draw this to our attention, but occasionally we'll see it and there's usually no symptom. But what should we be thinking about in regard to leukoplakia? Take us through how we should manage that.
So a significant portion, I guess, of my practice is a lot of mucosal surveillance or reviews and constant, I guess, monitoring of leukoplakia or other sort of unknown kind of mucosal changes. So leukoplakia, if it's looking like it's progressing, if it's quite thick plaque, then we do query, is there some sort of dysplasia? Are there cellular changes that are occurring that are, potentially putting that lesion at risk of becoming a malignant disorder? So leukoplakia does fall under what we call the OPMD, so oral potentially malignant diseases. So if that leukoplakia also has like a speckled appearance where there could be, certain smaller kind of erythema or some sort of, irregular, I guess, appearance to that, then these are signs that potentially this is something that's, a lot more higher risk than a standard, very homogeneous white plaque.
Yes. Do you tend to recommend, let's say there aren't those more concerning features, do you tend to recommend a biopsy regardless, or do you recommend maybe a photograph and observing and watching those patients. So is there a sort of a thought that they just should be biopsied regardless, so we can, if you like, clear the air and be reassuring to our patients?
Yeah, absolutely. I think biopsy is still gold standard. There are a lot of adjunctive, I guess, techniques or technologies that we use where we use certain, types of, what we call like a bioscreen, which is essentially putting light on it and checking if there's any loss of autofluorescence on that. So there are these other tools that we can use to kind of aid whether there's
Yes.
cellular changes
Yep.
that indicate dysplasia. But typically, if there's any doubt, any concern, a biopsy is first line. And that way we can somewhat rule out that at least that part that we biopsied of that lesion is not showing anything sinister yet. If it does show mild, moderate, anything like that in terms of mild dysplasia, then we know that the ongoing review or the surveillance of that site needs to be a lot more, focused, I guess.
Active, yes. Would you be the person who would then maybe resect that lesion, or is that more the domain of the oro?
Yes, that's more, I guess. Yeah,
You then direct them on to part of the team, and that's part of the team.
absolutely. Yeah.
Yeah. Have you had any unusual cases, I'm going to ask you, Asef, in the last, say, 3 or 4 months, being anonymous, of course, to the patient, but is there something you could maybe draw from your experience where you thought maybe this should have been referred a lot earlier,
Yes.
and it hasn't been? Are there any such cases that we could learn from?
Yeah, absolutely. I mean, if you say in the last 3 or 4 months, there's two probably that jump up to me. So the most recent one was probably in the last 3 or 4 weeks. What happened was a gentleman, 38, 39 years of age, relatively fit and healthy, no other medical conditions or medications or anything like that. He presented to us with an ulcer that he had noticed on his right cheek, and he thought it was just an infection. He had been going to his GP and then another GP who had been prescribing ongoing antibiotics, which did not resolve it. And I think it was about 4 to 6 weeks worth of, antibiotics. So that's substantial,
Yes.
and for something not to kind of settle down within that time frame. He read online, if you swish or use a hydrogen peroxide mouthwash, then it heals all ulcers. And to an extent, it is true given the antiviral effect that we know of that, and a lot of ulcers in the mouth do present, due to viral infection. So he did that, but then his face blew up. His face was just, I saw a photo. It was just, like someone punched him or Mike Tyson punched him. And by the time he got to us, it had reduced, but he still had this, asymmetry to his facial appearance. I looked inside, and it was a very sinister, extensive generalized ulcer on his right buccal mucosa, speckled, non-homogeneous. Just it was very angry, very raw, a lot of necrotic tissue and the smell. So these were all red flags just going off. And we obviously did what we did with the workup, came back with histopath confirming that it was a squamous cell carcinoma.
Right.
And then he was referred to the RMH head and neck team, and they ended up doing a maxillectomy, so resection of the jaw, and obviously plastics involvement to somewhat recon and treat the patient. So, it all started off with a small ulcer. It would have, it didn't grow to the size where, I guess his whole right half of the maxilla had to be resected. So, early diagnosis, early management is always key. I think, and it's a huge predictor predictor for the prognosis and outcome for these patients. So
those pathologies can advance very quickly too, which is what happened.
Absolutely.
Was he a smoker? Do you recall his?
Not smoker. He was. He used to chew betel nuts. Which we know, given it's a known carcinogen.
Yes.
Especially from South Asia, Asian continent. So unfortunately, I mean, actually, he did seize 5 years ago, so it had been sometimes since he had it, but still he had that.
Right. But that's interesting. Was there another case as well that you had that just
which was an interesting one actually. An 82-year-old gentleman. He had been seeing his regular dentist in regional Victoria, and he had been having bleeding gums and sensitive gums that just weren't settling. 80 years of age, we know, the prevalence or the degree of what we call periodontitis or gingivitis or some sort of, I guess, inflammatory changes of his gums and oral tissues is common, because we know, there's a lot of factors there that, I guess, reduce the ability for the patient to kind of, maintain optimum oral hygiene. So not a red flag, but then I think the dentist did some treatment, was not able to confirm or notice any improvements, so was referred to another specialist who, looked at the patient and said, this is not dental related, and you need to see an oral medicine specialist. He eventually got to my office. I had a look, and straight away I was noting subepithelial clefting. I can see a lot of redness, a lot of, sloughing of the epithelium. So ended up doing a biopsy, did some blood tests, and, it all kind of came back for conclusive for mucous membrane pemphigoid. So this was, at 82 years of age, his initial presentation, he's asking me, what have I done wrong? Why is this happening to me? And, it's an autoimmune condition. So it's not something that I can pinpoint to, or definitively say this was a trigger. So managing that was somewhat of an interesting conversation, but he was amazing with it. He's just like, I'm sure there's something else that will catch me. So,
are you involved with the ongoing medical management, or are you referring these patients? Do they get referred back
ongoing medical management? So,
to dermatologists?
So I guess once his condition. So, for example, this patient now would be referred to the immunobolus clinic. I'm referring him to the one in Royal Melbourne Hospital. In that Bullis clinic, there is an oral medicine consultant and myself as the trainee or registrar there, involved with the dermatology team. So we manage, I guess, a lot of the oral topical kind of treatment for these patients, and then anything that's needing, something like a monoclonal antibody, which is targeted towards the B cells, like what we call rituximab. So for a lot of the autoimmune conditions, that would be done in a I guess the tertiary center there. And then once things stabilize, then their ongoing mucosal surveillance potentially would go back to an oral physician or oral medicine.
Well, thank you for drawing those two cases to our attention. It's just so important for us to be mindful of the potential for a more serious underlying condition, early referral to an oral medicine specialist, and when in doubt, we progress on as quickly as we can. And we're all a team, aren't we? In this, we're all in it together to help our patients, and we draw upon colleagues' expertise. Thank you for sharing that. I was interested also in your thoughts about procedures that have been suggested to help obstructive sleep apnea, so orthognathic surgery, mandibular advancement splints, and so forth. Can you just give us a little précis on what they are? When should we be thinking about referring them? What sort of person is the right person to be referred? Can you tell us a little bit about that?
Absolutely. So the way we assess, we take measurements. We take what we call lateral cephs, which is I guess an X-ray technique, which looks at the side of the face and gives us all the structures there, and we take measurements to truly assess: is there a deficiency? Is there a retrognathia, as I mentioned, where it's a smaller jaw? Is there a compromise to the airway? So I guess once they've had those parameters ticked, then it does warrant some sort of intervention. So mandibular advancement surgery or orthognathic surgery versus a mandibular advancement splint are obviously completely two different types of treatment. The surgical intervention would be with an oral and maxillofacial surgeon, and they're very good at this. I mean, this is probably one of their routine procedures, where they do bring the jaw forward, and that not only addresses their appearance or aesthetics concerns, but helps open up the airway and aids in that type of improvement. Whereas you mentioned mandibular advancement splint, is that correct, Luke?
Yes.
Yeah. So that is more an oral appliance that is worn essentially once you've gone to when you're heading to sleep.
Yes.
What it does, it actually a similar concept. It brings your entire jaw forward, and with the idea that the pharyngeal airway will also become more patent as you're bringing all the structures forward. And it has shown to be very effective in mild to moderate obstructive sleep apnea patients. I know one of the last meta-analysis I was reading, it was reducing the AHI by 7 to 11.
Yes.
Episodes.
Yes.
So that's...
Is that splint? I've heard. I've recently been been away on a vacation actually, and someone I met was saying, oh, that they were wearing this splint, but I wasn't exactly sure how he said it was very comfortable and he did not need any, sleep apnea devices, which was, he really enjoyed wearing it. And just can you just describe what it is like, that splint? Like, how does it sit exactly? Can you tell us?
Yeah. So have you actually tried a CPAP machine, Luke?
I haven't actually tried one.
You're the spitting image of a very healthy person. So
I don't know. I never want to have one.
just for fun,
I'll do
maybe.
whatever I'll do whatever I have to.
Just for your own kind of experience and fun. I mean, CPAP. Listen, I still believe it is somewhat gold standard for those moderate to severe cases of OSA, but we know compliance and I guess the comfort to the patient is the biggest deterrence for it. Where a lot of patients just find it too uncomfortable to do wear the mask. So, next in line would be a mandibular advancement splint, which is essentially, it's a custom-made appliance. So it is made by a dental specialist or a dentist that's experienced in this field, but it's essentially a custom-made appliance that encompasses the entire upper teeth and entire bottom teeth as well.
Right.
And it's interlocked so that you're able to titrate or move the bottom jaw forward or backwards to the desired amount. And that way you're adjusting the position of the jaw and its associated soft tissue structures. So it is comfortable in the sense that it's custom made. So it's not like one, size fits all. So it is made sure that it fits absolutely perfectly like a glove to a hand. And then, the titration or the advancement of the jaw or the mandible, you don't need to go to the extreme within the first night. You might do 1 millimeter every fortnight, every week, every month, until the patient is somewhat adapting and allowing that advancement to occur. So, if the first couple of weeks, I tell all my patients, expect that you will feel like you've got something foreign in your mouth, and that's because you do have something foreign in your mouth. However, you do get used to it, and the benefits, obviously, we know the benefits of improving your obstructive sleep apnea.
So seem to be very significant.
Absolutely,
something for us to be aware of. Just in regard to orthodontic surgery, the sort of person that might be referred would be someone who's got that retrognathic sort of look, the jaws sunk back. And what sort of age are we talking about in general? That is there an age limit above which it's not appropriate for that referral?
Sure. I think, I don't think there's a age, like a upper limit that they would, unless, the patient is 100 years of age and you really don't think, those are obvious kind of reasons. But, the early diagnosis is always there. So when, as we grow, we know the craniofacial structures, as it develops, the mandible does have what we call like a differential horizontal growth factor. So we know with age, with growth, the mandible does advance more so rapidly than the maxilla. So if we know after taking the measurements, looking at the parameters, we know that the mandible growth will catch up, then you really don't jump to surgery.
Yes.
But if you know that it's somewhat, significantly deficient or not in the ideal, I guess, numbers in terms of the measurements, then it definitely warrants some sort of surgical intervention in that case to, aid everything else that comes with it.
Yes. And in a younger person, we might overcome dental crowding, perhaps with the need for some dental removal of the impaction of molars and so forth might be overcome by that.
Mm-hmm.
Look, thank you for bringing us up to speed on that one too. That's very interesting, and I like the idea of the mandibular splints very much. Just tell us a little bit about something that's become extremely popular, and people are travelling to Turkey in particular for this. And that is and maybe India also, that is the concept or the topic of dental implants. Tell us a little bit about this. This has become a massive thing.
Huge.
Tell us a bit about it. It's a big topic. What sort of rehabilitation should be considered afterwards, and what sort of problems you're seeing with that, if any?
Sure. No, this is a very huge, I guess, topic right now, and it actually has been for some time, but I feel like it's probably more so under the limelight even in more recently. So dental implants and cosmetic dentistry, these are the number two, I guess, dental tourism that we know, or at least Australian residents. So dental implants, it is a surgical treatment where we do place a medical grade titanium oxide implant into the jawbone in hope that it does osseointegrate. And then once it's osseointegrated, we put a prosthetic or a dental crown on top to, I guess, rehabilitate that missing teeth or tooth. So I guess, when you're going abroad, you don't know what abided by. And this is where a lot of risk of, I guess, infection, a lot of risk of, other damage to other structures and other teeth in the mouth is somewhat common. Don't get me wrong though, Luke, I've seen some amazing work done from overseas, but then I've seen some horrendous work, and probably price is a factor here. So I know a patient of mine who had gone to Serbia, I believe, so Europe, and had extensive work done, came back, looked amazing, and then a month or two later, he called me because he was in severe agony, severe pain, and I think this was either Easter or this was it was some public holiday.
Inconvenient time.
Yeah, yeah. He was lucky he had my contact because
yes.
otherwise I would have. Yeah, exactly. Anyway, I ended up seeing him. We had to extract, surgically remove an entire quadrant of his teeth.
Impacted, right? Okay, of those teeth.
But you can imagine, but
because of infection
because of the infection and also poorly kind of fitting prosthesis that was done as well. So it really compromised, and infection in the jawbone. Unfortunately, the way it works, it literally resorbs or destroys the jawbone, and then you have no other option but to remove that kind of area of infection. And it's not just with antibiotics. It does require some surgical intervention there. So that's one. The other thing is, veneers, crowns. Everyone wants, a nice, beautiful white smile, I'm sure. So, and I understand the motivation for patients, I do. But I guess, the complications and the mistakes that we see back here, no clinician wants to touch it, and then the patient's in a lot of trouble, and it's not a good outcome for them at all.
No, that's right. It's a difficult problem when I guess you take responsibility in your own hands when you do seek that, but it generally is price driven, I think, isn't it?
Absolutely.
Yes. So that's a wonderful tour de force through the world of oral medicine, Asef. Take me through your future. Like where do you see yourself in the next 3 or 4 years?
Yeah, that's this is a question I probably asked myself and a lot of others also.
You look like professorial material to me.
I don't think I do enjoy my clinical practice. So I think, I'd love to have my oral medicine practice, but then I also like to have somewhat of a specialized dental practice as well. So these are the things that I enjoy doing. But in 3 years' time, I'll be back in my regional Victorian city, otherwise known as Geelong.
Cats.
Yeah, exactly. So, practicing there, and I think that's my short-term goal. Long-term goal, I'd love to say, travel with work. That would be amazing, and there's a lot of opportunities, as you would be doing yourself, with going to conferences and teaching and etc. So
yes, and helping in developed countries as well.
Exactly.
Asef, that's great. We wish you very well. I really appreciate your expertise and honoured that you could join us tonight on Everyday Medicine. Take care. All the very best. We'll see you again soon. Thank you. Thank you. I'd like to thank you for joining me in the conversation today, held with Dr. Asef Anwar on oral medicine. I found this fascinating, and it's opened my mind up to the importance of checking for oral hygiene when we're seeing our patients in the clinical setting. Well, during the podcast series, we'll be covering a wide range of topics, and we welcome a new guest next week. Please join us then. These discussions are not intended as specific medical advice for patients, but as general information only, and reflect the opinions of the guests interviewed. Requests for new topics to be reviewed and comments about the conversation you've listened to are welcomed and may be emailed to manager@gihealth.com.au. Thank you.